I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
The next speaker will be Dr. Larry Squire, who will speak on long-term neuropsychological effects of objective and subjective knowledge. Although the topic is neuropsychology, which implies cognitive function and brain function in a rather broad sense, the neuropsychological issue in the case of ECT is memory. The problem of memory impairment is central to the adverse effects issue because first, from the patient's point of view, memory problems are the most prominent adverse effect of ECT, and second, tests that quantify memory impairment are extremely sensitive to brain injury. This review of the long-term effects of ECT on memory focuses on three questions that must be raised in any discussion of memory and memory problems. First, what is the patient's own perception of memory experience? Second, what is the status of new learning ability long after ECT? That is, here we speak of day-to-day remembering, or the problem of integrated amnesia, the status of memories that are trying to be established after the time of ECT. And finally, what is the status of remote memory, or memory for events that happened before ECT? And here we're speaking of retrograde amnesia. Can I see the first slide, please, which will help place this work in the context of contemporary neuroscience. This is a cartoon, a medial section of the brain that makes a point that has been known for a long time, for nearly 100 years, that memory loss is associated with injury or disease or dysfunction in two brain areas. The medial temporal region here, which includes the hippocampus, the amygdala, and overlying cortex, particularly parahippocampal gyrus and area THPF, and in the area in the diastolic midline, most prominently the mammillary body and the dorsal medial nucleus of the thalamus. In memory impairment associated with damage or disease or dysfunction in these areas is of a particular type, what is known as the amnesic syndrome. And when these structures are damaged by disease or stroke by progressive neurological disease, for example, or by disabling stroke, the impairment is permanent. When the dysfunction is temporary, the impairment is temporary, as in the case of transient global amnesias or in many cases of head trauma. The memory loss initially associated with ECT resembles the profile of the amnesic syndrome. Therefore, it seems reasonable to think that ECT is having a particular effect on these brain structures, that is, once the patient is recovered from the global confusional state. The question then is whether this effect is permanent or whether it is temporary. The results to be reviewed here indicate that it is temporary, though it needs to be understood that even a temporary diminution of memory functions leaves some permanent loss in the form of a gap around the time of onset of the memory disorder. Questions that need to be addressed then is how long is temporary and how large is the residual and permanent gap. Next slide comes from a prospective study of our own in which we asked patients before treatment, 6 months after treatment, and 3 years after treatment to describe their own experience of memory dysfunction. And here is the median response 3 years after treatment for 31 patients. These patients described an anterograde amnesia of about 2 months and a retrograde amnesia of 6 months. Now this is the classical pattern of residual gap as perceived by the patients. The anterograde amnesia we think is critical, as some of the data that I'll describe to you will indicate. Because the anterograde amnesia initially associated with ECT, we understand to be a failure to form new memories or store it in a useful way. Therefore, one would expect, as recovery from anterograde amnesia occurs, there will be some permanent residue there of the memories which were not formed during the time of anterograde amnesia. The retrograde amnesia is a little ambiguous in terms of interpretation because these same patients before ECT described some problems remembering for the 5 months of preceding treatment. So it's difficult to disentangle here the fact that patients were in a time of their lives when they weren't remembering and learning very well anyway, from the fact that there may be, as some of the data will show, some permanent and retrograde amnesia embedded within this period of 6 months. Just to begin, it's useful sometimes to compare the initial memory loss associated with ECT with other kinds of amnesias. And here we see the results initially soon after ECT, the domain that Dr. Sackheim addressed, 1 hour after ECT. Sensitive test of parasocial learning where patients are asked to associate unrelated word pairs like army table, frog jail, elephant bouquet, and so on. And then they're in a pass later on, they're given the first word of the pair and asked to produce a second. And here you see the results of various control studies, including depressed patients who are about to receive ECT. And then you see the results for 4 kinds of patients having amnesia, including patients who are tested 1 hour after the 5th bilateral treatment. The other groups are 4 patients who have amnesia as a result of hypoxic ischemic injury, the well-known amnesia associated with alcoholic Korsakoff syndrome, and the celebrated case NA who has diencephalic brain injury as a result of penetrating brain injury. So initially the amnesia can be classified as severe. It's easy to distinguish from depression, and it's easy to distinguish from the effects of antidepressant medication. This is one from a group of tests that were given to patients 6 months after a course of bilateral treatment. In this slide, you're seeing the test is a test of giving patients a short paragraph of prose to hear. They're asked to repeat it back immediately without a delay, and then the next day, and then in some cases 2 weeks later. And the results are for, in the short line here, for patients before ECT. They show a little forgetting over the course of the 24-hour retention interval. The dotted line is for patients who were tested in the afternoon of their 5th treatment. That is, they're given the story to hear, they read the story in the afternoon of the 5th treatment. They repeat it back rather well, but the next day they're quite amnesic for the experience. And this is then from another group of patients who were tested in a retrospective design 6 months after treatment. And that, as you can see, shows recovery to the pre-ECT level. And although I don't show the data here, it also matches exactly the performance of patients who had had unilateral ECT 6 months earlier, or these are for bilateral ECT 6 months earlier, or for patients who were depressed and hospitalized but did not receive ECT 6 months earlier. Now the question that comes up, of course, in studies like this is, well, how sensitive is this kind of a memory test? That is, negative results are often difficult to interpret because it's always possible to suppose that if a more sensitive test were developed, then a memory impairment would be found. Absence of evidence is not evidence of absence. In this study, one of the most sensitive ones that we could devise in our study was a test of incidental learning, where 6 months after ECT, we visited the patients at their homes. We gave them some memory tests, and then 2 weeks later, they were asked without forewarning to describe in detail both the test that they had received and the appearance of the examiner, who happened to have worn the same bow ties and badges and identifying material 2 weeks earlier. And there you see that again, there was no evidence for persisting memory impairment. The patients that had not received ECT, patients that had received unilateral ECT, the patients who received bilateral ECT performed about the same. And subsequent to the study, a somewhat more ambitious and larger scale study was done by the group in Edinburgh, Weeks, Freeman and Kendall, involving some 51 patients who had received either bilateral or unilateral treatment and who were compared and followed over a period of 6 months with 51 other patients who did not receive ECT, with 17 different tests, some involving testing memory function, others involving other cognitive functions. And although there was still some deficits measurable as long as 4 months after treatment, at the 7-month follow-up time, there was no differences between the group that had received ECT and the group that did not. And in their review of the literature, they estimate from the literature an average time of recovery from anterograde amnesia of 2.5 months, which accords rather well with the patient's own perception of the persisting anterograde amnesia, as I described for you in the first slide. Now, the second domain of memory impairment is important to address, aside from anterograde amnesia, is the domain of retrograde amnesia, that is, loss of memory for events that occurred before the time of ECT. And these questions about retrograde amnesia can be addressed by objective tests that ask questions about events that were in the public domain so that we know what the answers are and we know whether the patients are answering them correctly, and also by tests that seem perhaps to be more sensitive that ask detailed questions about when the patient's own autobiography, which have the disadvantage that they're not always easy to corroborate the answers, but they do have the advantage that a great number of questions can be asked to individual patients and one has the impression that the test is quite sensitive. This then is one test of the first type in which patients are asked detailed questions about television programs that were only on for one season during the last many years. In this case, patients are asked a question about, tell me as much as you can about such and such program. And then their answers are tape recorded and transcribed and scored by raters for the amount of detail. And here you see that before ECT, there's a forgetting curve in normal memory, that is, patients are able to recall more about programs that aired recently than about programs that aired long ago. After the fifth treatment, there is some selective memory loss, selective temporally limited retrograde amnesia that affects memory for events that occurred in the previous few years without causing a significant loss either here or here, events that occurred more than 3 years ago. The recovery process seems to begin after the time the treatment is completed. At 1 week after treatment, there's some partial recovery of these events, and by 7 months, there's no longer a measurable amount of retrograde amnesia for these events that occurred in the previous few years. Much the same conclusion follows from this kind of study in which patients are asked public events questions. They're asked to supply short answers to rather detailed questions about events that were in the news in the 50s, the 60s, and the 70s. Here you see the performance before ECT. Now, the fact that people were doing better in the 50s reflects the test rather than people's memories. That is, these are just a collection of questions. The 50s questions can be a little bit easier than the 60s and 70s questions. After the fifth ECT, again, there's this loss that seems to be greatest for the most recent decade as compared to this distance here and this distance here. 1 week after treatment, there's now some for partial recovery, although it doesn't quite seem to be complete. And by 7 months after treatment, patients have recovered their ability to recall these events. Turning to the domain of personal memories, we, like Dr. Reagan, were impressed and troubled by Janus's studies, which were way ahead of their time, done in 1950 and 51, in which seemed to show long-lasting and possibly permanent memory loss in the autobiographical domain for a group of patients who had received 20 bilateral treatments and who were followed out to 10 to 14 weeks in a follow-up study. A subsample of 5 patients were followed 10 or 14 weeks. But what Janus didn't address systematically in this study was the time period to which the forgotten memories belong. So we wondered if perhaps there might be a tendency for the more permanent memory loss or the more long-lasting memory loss to belong to recent time periods as opposed to the more remote time periods or generally over the whole life. So we designed a Janus-type autobiographical test which controls which controlled the factor of time and age of memory. And these are the results for all the questions on the test put together. What you're basically seeing here is that before ECT, patients who are about to receive bilateral ECT and control subjects perform about the same on the test. That is, they're generating about the same number of facts, same number of details about the 10 questions on the test. 1 to 7 days after ECT, the control subjects do even better. That essentially means that not only do they remember what they said the first time, but now they were able to add a little more to their reports. Whereas the ECT patients do worse, which represents a true retrograde amnesia. That is, they're less able than before to recall information about these events. But when all these material is averaged together, there's recovery of this material at 6 months after ECT. What we did then was to separate out from these 10 questions the 3 questions which asked about most recent events. And here you see the results for those 3 questions, showing a significant and long-lasting and we think probably permanent memory loss associated with ECT for those events which occurred relatively recent in the patient's life. In fact, of the 3 questions, the one that showed the most loss, the one that's responsible for most of this impairment, is a question about the circumstances leading to the patient's, the circumstances of the day of arrival at the hospital during the course of treatment. And that event had occurred from 2 to 36 days before ECT with a mean of 11 days. So what we're seeing here is permanent memory loss for events that occurred 11 days before the course of treatment. One of the other questions was about a question about the Christmas before last, which did not show any permanent memory loss. And the other question was a question which was from 0 to 37 months old, a question about the Watergate incident, which had begun with a Watergate break in 37 months before the study began, and which was still in the news at the time of the study. So, and that question did show some evidence for permanent memory loss, but it was unclear where in the 37 months those memories were drawn from. Speaking mostly now about bilateral ECT, let me say something about the comparison between right unilateral and bilateral ECT with respect to retrograde amnesia. That point can be made perhaps best with this diagram, which comes from a recent study we did in which patients took a skill learning test involving reading words before treatment and on the day after the first treatment. And then some month, 35 days later, and 2 weeks after the last treatment, they were asked a series of questions. They were interviewed as to their memory for the learning situation itself. And you see that where the maximum score is 9. You see that the patients who were in the depressed control group were not receiving ECT answered all the questions correctly. Patients who had received right unilateral ECT were intermediate in their memory. They remembered some of the material but not others. The bilateral patients were almost totally amnesic for the material. In fact, of the 5 patients in this group, 2 of them denied that they'd ever been seen by the examiner before. So again, we see evidence, particularly for that sensitive time domain just prior to time of treatment, for permanent memory loss associated with bilateral ECT, and to a lesser extent from right unilateral ECT. In most studies, right unilateral ECT arranges itself intermediately between no ECT and bilateral ECT as far as memory loss is concerned. Let me pursue this issue of variants of ECT by drawing, and this is the same point that Dr. Satnam did, namely that we now have available 2 forms, 2 variants of ECT, the sine wave, the conventional sine wave method, and the pulse, bipolar pulse method. And in a recent study done at Duke by Dr. Weiner, which I was able to collaborate with, and we looked at patients 6 months after treatment with these Janus-type questions with this autobiographical information, questions about the patient's personal life. And here you see that these 4 combinations of treatment, the sine and the pulse and the bilateral and unilateral, essentially rank themselves out here with sine bilateral producing the most impairment on this autobiographical memory test, pulse bilateral next, sine unilateral next, and pulse unilateral not significantly different from control subjects on this particular autobiographical memory test. Let me turn next to the question turn back really to the question of the memory complaints that are associated with ECT. We know that about 50% of patients, even 3 years after treatment, will say that their memory problems that they still have memory problems, and they tend to attribute these memory problems to the ECT process. As I showed you in the very first slide, much of that complaint would appear is due to this gap, which persists, a gap in their personal life around the time of treatment. We thought we might be able to get at this in some more detail by developing a self-rating scale which would ask the patient questions about his memory, a questionnaire that we designed to include questions that would both be sensitive to the kinds of memory problems depressed patients have on the one hand, and questions that would be sensitive to the kinds of memory problems that amnesic patients have on the other hand. And this shows the performance of 35 patients on this self-rating scale before bilateral treatment and 1 week after bilateral treatment. Now this is a scale in which they rank each item on a -4 to +4 scale. So 0 would represent no perceived impairment, -4 would represent very bad impairment, and -3, -2, -1 would be in between. And what we've done here is to order the items so that they from the items that show the biggest before-after difference to the ones that show the least, in fact, slightly reverse difference. And what you see is that just a few different things. In the first place, patients who are depressed do have memory complaints. And they tend to be sort of global in a sense. They have a similar memory profile, a similar complaint across all items in the test. 1 week after ECT, and I think, well, 1 week after ECT, a couple things have happened. In the first place, memory complaints are now more severe than they were before treatment. And second, they have a different pattern. That is, now some patients, some items are complained about are rated worse more than others. So that one might think of this as the depressed complaint profile, and this as the amnesic complaint profile, because indeed we know from testing that memory problems are present at 1 week after treatment. So we asked the question, at 6 months after treatment, when patients do have these memory complaints, do they resemble the pre-ECT picture, or do they resemble the 1 week amnesic picture? And the results were very clear in terms of favoring the second alternative. That is, here we just see now regression lines through these points. Before ECT, this flat, depressed pattern of memory complaints. 1 week after, you see this amnesic pattern of complaints. And 6 months after, you see two things. First, there has been a lessening of memory complaints, which is veridical in the sense that we know that memory functions do improve between 1 week after treatment, 6 months after treatment. And secondly, we see that the pattern of experience, the perceived perception of memory problems in 6 months after treatment conforms to the 1 week pattern. So we interpret that to mean that the experience that the patient is having at 6 months after treatment is an experience of amnesia, and not an experience of depression, not a chronic loss of self-esteem that was always present or something that would have continued throughout their life, but rather something that's been altered as a result of their experience with ECT. And there are three interpretations of that finding. The first is that they are continuing to have a global kind of memory impairment, but one that is so subtle that it is not yet detectable by any test that neuropsychologists have ever been able to devise. A second possibility is that their memory complaints refer largely to this gap, which we know is present. If we had known about the gap as clearly when we did this study as we do now, we would have gone on and asked these patients detailed questions about the gap, but we're not so aware of the gap at the time we did this study. And the third possibility is that patients who go through, as a result of bilateral ECT, a severe period of amnesia, gradually recovering from that amnesia in what is presumably a negatively accelerated curve where the recovery is first fast and then less and less and less. Patients may have difficulty knowing when they ever reach back to a normal level, and they come to doubt that their memories are fully recovered. The last slide I'll show you contrasts the experience of patients who receive unilateral ECT with the experience of patients who receive bilateral ECT. This is the same slide I just showed you, and this shows that the patients themselves are very sensitive to the differences in memory dysfunction associated with bilateral and unilateral ECT. So let me summarize by saying the patients who have had received ECT eventually perform as well on new learning tests and on remote memory tests as they performed before treatment, as well as other patients who have not received ECT. Now, that statement only applies to patients who have received what I would call the typical number of treatments, 8, 9, or 10, and does not meant to apply to patients who have received much larger numbers of treatments. However, information acquired during the days and weeks prior to and following bilateral ECT is often permanently lost. Bilateral ECT affects memory considerably more than right unilateral ECT, and this is reflected as well in patients' own reports of their memory function. More recently, pulse ECT has been shown to affect memory still less than sine wave ECT, so the combination of sine wave bilateral ECT is most deleterious to memory, and pulse unilateral the least deleterious to memory. Memory complaints are a prominent feature of the ECT experience. A sense of continuing memory problems might occur because persons who have made a gradual recovery from amnesia tend to doubt that they are fully recovered. We all occasionally have faulty memories. At least to one who thinks about memory most of the time, it seems to me to talk about common memory problems as everyday commonplaces, talk about the weather. But how can we know when memory failures are normal and when they might be attributable to a previous course of ECT? It seems to me that it would be very hard to know, and I would think that this would be a very compelling and troubling source of problem. Finally, ECT differs from many medical treatments in that it is not a single thing given at a single time. A course of ECT involves different numbers of treatments for different patients, and there are different kinds of ECT: bilateral, unilateral, pulse, and sine wave. Because these variables, and especially the kind of ECT, are of considerable importance for understanding the risks of treatment to memory, it would seem advisable to keep these distinctions in the foreground in all discussions and recommendations involving ECT.
Thank you.
One shock treatment can equal 150 joules of energy. This is equal to dropping a hammer on someone's head from higher than a 5-story building.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or pulsed, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320-some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer used to hit an amp. I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but that should be the point.
Well, just a minute.
I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got
All right, out with your gum. Out with your gum.
Okay, this won't hurt. It'll be over in just a moment.
What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well,
Now just bite down on it. That's right. Just bite down. Now bite down on it.
good. Are you ready? Here we go.